With me today are two hardworking and dynamic PGs, Dr. Vanessa and Dr. Chetana. So our aim is to make it as interactive as possible, so that as though you are sitting and you are presenting the cases, that is what we will aim to. So what we'll do is that have an exam, there will be two long cases and then spot rank some discussion. That is what we aim to do. I think we will start. Shall I share the screen?
Yeah.
Is the screen visible?
Yes, it's visible.
Yes.
Clear.
Yes. Yeah. Start.
Good evening, everybody. I'm Dr. Vanessa. I'm a postgraduate in Father Muller Medical College. So today I'll be presenting a case of a 33-year-old male who presented with fever and abdominal pain, which was on and off since 1 month. He had similar complaints over the last 2 years. His lab parameters showed elevated ESR and he had anemia. So they got a USG abdomen done, and USG abdomen showed a few hypoechoic areas in the subcapsular location of the liver, and there was also a portal vein thrombosis, and there was also splenomegaly. So to evaluate further, they got a CT, abdomen and pelvis done. So I'll be presenting this CT. So here you can see this is the scout image, and the scout image is unremarkable. There are no abnormally dilated bowel loops, and there are no calcifications. Next, scrolling through the thin axial plane sections of abdomen and pelvis. So here we can see that there are a few hypodensities which are seen in both lobes of the liver. There is also splenomegaly. There are few vascular calcifications and prostatic calcification. There is no ascites. There is no hyperdensity within the liver, and no calcifications seen.
So why actually we do plain CT? What is the point in doing plain CT?
A plain CT can detect any calcification, fat, hyperdense, like as in hemorrhage, and even foci of air. Also, when we are evaluating liver lesions, to have, like, before we give contrast, to know the baseline characteristic of the lesion, we can see it on plate.
Can you avoid doing plain CT, or what is your opinion? Because as you know, it causes radiation. Patient is fairly young, 33 years. So by doing plain CT, we are giving radiation to him. So can we avoid doing that? What is your opinion? Should we, or should we do always plain?
In few centers, based on, like, if they already know what they are evaluating, then they ask for a particular phase or a particular protocol, and only that is done. But in our institution, we do plain. And
it's an institution policy, but there are many institutions where the plain CT is not done directly to go for an arterial or a portal venous phase. It is not a must and should. You can, to some extent, see the calcification on the contrast CT also. The only thing is the hemorrhage is the only one that is difficult. So that and with the newer generation of CTs, it is possible to get a plain-like images from the contrast also. Okay, so let's go to the arterial phase.
now,
So before going to the arterial phase, what is this arterial phase, and what are the liver phases that you know? Can you tell roughly?
so we for liver lesions, we use triple phase CT. So this has early arterial phase, which is done.
How much of contrast is injected? Do you know? Yeah.
100 ml contrast we inject at 3 ml per second through a 18 gauge cannula.
Okay.
So the early arterial phase we see
What is the time period?
15 to 20 seconds after injection, sir. In this, we see the only the arteries opacified, so we can see the arterial anatomy. Then is the late arterial phase, and this is around 30 to 45 seconds. In this, we see the hypervascular lesions in the liver. Because only these will enhance against the liver has still not enhanced because the portal vein is still not fully opacified. Then we have the portal phase,
What time is the portal phase?
around 50 to 60 seconds.
Around 70 to 80 seconds.
70 to 80
roughly.
seconds. So in this, there is maximum enhancement of the hepatic parenchyma, and then there is equilibrium phase where it is done at around 6 to 7 minutes. So there we see for any tumor washout or if there is any retention of contrast, because some tumors like cholangiocarcinoma can retain contrast, or a central scar can still retain contrast, but an HCC will show washouts. So that is an equilibrium phase.
will enhance in which phase? Early arterial or late arterial phase?
HCC will enhance in late arterial phase.
Yeah, this is an important point to remember. Early arterial phase is only to look at the arterial anatomy and there is any flush, whereas the late arterial phase is where generally you see the HCC enhancing. In the portal phase, so liver tumors, why do we do this? What is the point in doing these multiple phases? If you do the portal phase, most of the time you will see the tumors, isn't it? Why you're adding these two additional phases? What is the point?
Because though like the actual blood supply to the liver is such that 80% is supplied by the portal vein and 20% of the liver parenchyma is supplied by hepatic artery. But for an HCC, all the vascularity is coming from the hepatic artery. So we have to include arterial first. And it will wash out, which will be seen in equilibrium.
In the portal phase or in the, it can wash out. Or in the equilibrium phase, it can wash out in both the phases. And another thing is, if there is a hypervascular lesion, the lesion might lose contrast and can be similar to appearance in the portal phase. That is also one of the reasons why do add these so many phases, so that we don't skip any lesion. Every lesion is picked up in our liver protocol. So that is the reason we do 4 phases in general. Okay, so that's good. So now let's see what is there.
So now we are scrolling craniocaudally in the early arterial phase. So this is the aorta, and we can see that the celiac trunk is well opacified, and this is the common hepatic artery. And here you can see that the left hepatic artery is narrow and caliber compared to the right hepatic artery. And this right hepatic artery branches are seen coursing through the hypodensities that we had earlier seen. The splenic artery is seen well opacified. The superior mesenteric artery, the renal arteries, and the inferior mesenteric arteries are also inferior mesenteric artery is well opacified.
But we do not identify anything separate from the plane, isn't it?
Yes.
Yeah. Okay. Next.
This is the late arterial phase. So as we are scrolling, we can see that there are few hypoenhancing areas in both lobes of the liver. And these areas, they appear very ill-defined or like geographical, and they are predominantly present in the periphery of the liver. Now, this is the portal phase. So in the portal phase, we can see that all these areas which were hypoenhancing in the late arterial phase, they are still hypoenhancing, and few of them show peripheral enhancements. And we can also notice that there is atrophy of the lateral segments of the left lobe of liver, and the caudate lobe is enlarged. There is also splenomegaly.
Some very capacity also already seen, but you can see that there is thrombus filling defect is there within that. Portal vein is there, it's I think maybe we can like multiple other collateral, yeah, multiple other collateral vessels. Yeah.
Multiple periportal collateral vessels are seen.
So
Similarly,
this is the gallbladder.
this is the gallbladder, and
Anything is there around the gallbladder?
even around the gallbladder there are some collaterals.
Do you know when you see collaterals around gallbladder, what importance it has got?
Uh,
In general, no, that is a clue that the portal vein is thrombosed. Like you can get collaterals in spleen, around pancreas. But if you get collaterals around gallbladder, usually it means that the portal vein is thrombosed. That is one more clue that the portal vein is thrombosed. Okay. So here you said that the portal vein is partially thrombosed. There is still flow, and there are multiple collaterals. There is splenomegaly, and there are multiple liver lesions. So this we can know. Then
there are also some lymph nodes.
Okay.
There's a pre-iotic and
is there a
some
small,
lymph nodes.
small lymph there?
There is no evidence of similar such lesions elsewhere, like in the spleen. And then there are no other like mass lesions involving other organs. There is no ascites.
Appendix, all this everything normal. Okay.
Yes, the bowel is normal.
Kidneys and adrenals are normal.
Kidneys and adrenals are normal.
Bones are looking normal. So what is
The
that?
visualized lung bases are also appearing normal.
So what are you trying to say about this?
This patient who had a background
Can you
history.
show me?
So with the history of abdominal pain and fever, this patient's imaging findings are that he has portal and splenic vein thrombosis with multiple collaterals. Along with that, in the liver, there are multiple hypo-enhancing geographical areas, mostly in the periphery, and few of them showing peripheral enhancement. So putting these features together, my first differential would be hepatic infarctions. Because these lesions they have a geographical pattern predominantly present in the periphery. There is background of portal vein thrombosis, and also these hypoenhancing areas, they remain hypoenhanced throughout, like even in the venous phase.
This is possibility hepatic infarct.
Yes.
The patient is having fever, so there is splenomegaly, but can you say could this be some infection?
It
It can be evolving abscess or anything like that.
be evolving abscess. That would be my second.
That will be second question. See, one thing I want to ask, actually, these hepatic infarcts are extremely rare in liver. Can you tell me why?
Because like the liver has dual blood supply, so like if there is portal vein compromise, then the hepatic artery will try to compensate.
So, how is it different about it is infarct, but we have to be very careful because both have to go off. Only then generally you get hepatic infarcts. So now I'm asking, there is portal vein thrombus. So if you see portal vein thrombus and large liver lesion, what should be on the back of your mind?
HCC.
So can this be HCC?
This is not. This can't be HCC, sir.
Why?
Because there was no washer.
See, when there is a large HCC, there may not be all the typical features. So one way is that to differentiate is that you can actually see, if you see the arteries are going through that without much, all the vessels are going through that. Even an ultrasound when we did, we could see the vessels going through that. You can see the vein, you can see the hepatic vein going through that. It will never happen within a mass. So either it has to be some sort of a fatty sparing or some sort of an infarct, because only these are the regions which cause like this. So this is the I know it's not very clear, but on ultrasound we could actually see the vessels going through this. So that is a very strong picture which says that it is unlikely to be mass. These are the two possibilities, like probably it is some sort of an infection or it is some sort of an infarct. We couldn't make out what was the final diagnosis. So what happened finally?
So the patient underwent an investigated FNAC from the right lobe lesion, one of the right lobe lesions, and the FNAC came out to be as granulomatous inflammation, and they had also sent a sample for PCR gene expert for Mycobacterium tuberculosis, and it was positive for tuberculosis. So the final diagnosis was that these were tubercular abscesses, and then the patient was started on ATTs.
Patient has improved also. This is a very unusual case of a liver tuberculosis. Maybe there was underlying infarct, we don't know. But on the top of that, he has got an infected, most likely tuberculosis. Okay. So I think we'll go to the next case. Any questions you want to ask, ma'am, or anyone in the audience want to ask about this, or shall we go to the next case? Yes, you can introduce yourself.
Good evening. I'm Dr. Chetna Sustanpuri, postgraduate from Father Muller's Medical College. I'll be presenting the second case. This was a case of a 74-year-old male who came with complaints of easy fatiguity. General physical examination was unremarkable. Lab parameters showed elevated AFP levels. AFP was around 3,500 nanograms per milliliter. So, in view of elevated AFP, CCT abdomen pelvis was done. Going through the scout film, which includes lower sections of the chest, abdomen, and pelvis, the bubble loops appear grossly normal and are not dilated, and there's no evidence of any calcific lesions.
I think plain will contribute, isn't it? We directly go to the arterial phase, plain any finding inform, anything is there. Yeah, we'll go to the that's what we can go to the arterial phase, early arterial and late arterial.
So, scrolling through the axial sections of the early arterial phase, we can see liver is shrunken in size, and the surface appears nodular. There is enhancing lesion seen along the walls of the right, left portal vein, and also the main portal vein, and few segmental branches of the right portal vein. And this enhancing lesion is causing the expansion of the portal vein. Gallbladder is partially distended and is seen separately. There is mild ascites.
We'll see the other findings later on. So we'll focus on the liver. So you said liver is what, reduced in size, is it? See, this is the left lobe and this is the caudate lobe. You think they are reduced? Which lobe is reduced? Which lobe is reduced? The right lobe is reduced in size, and the left and the caudate lobes are what happened to them? They have become this is called as the volume rearrangement. Okay, so right lobe definitely will reduce, and the left and the caudal lobes are increased. Do you know any ratio which suggests how to look for cirrhosis? What are the criteria for cirrhosis? What is the ratio that is generally employed?
Simply we look for caudal lobe to right lobe ratios. So it is measured by drawing 3 lines. So the first line is drawn at the level of the portal vein along the lateral wall, and the second line is drawn along the medial border of the caudal lobe, and the third line is perpendicular to the first line. So the third line represents the diameter of the right lobe, and the distance between the first line and the second line gives us the diameter of the caudal. So on dividing the caudal lobe diameter by the right lobe, we get the caudal lobe to right lobe ratio. If it is more than 0.6 or 0.7, then we consider that there is hypertrophy of the caudal lobe with
indicative of chronic disease. Yeah. Other features are, as I said, there is atrophy. So you will see here what is called as a notch sign, where you see atrophy and the liver, as the liver is withdrawing. So these are some of the signs on which you can diagnose cirrhosis. But remember that many times there may be cirrhosis, but the CT may not show. So that also is that. But these are in general signs in which we detect cirrhosis. Okay, so you detected cirrhosis, and then second point, what you said, I didn't catch that. What about portal vein? What you said about the portal vein?
In the arterial phase, the portal walls of the portal vein and the lumen is enhancing. So
is there any abnormality, like when you say in the arterial phase, the portal vein is enhancing? What does that mean actually? Is it normal or abnormal? So what does it indicate that?
It indicates that there is some lesion, tumor, there is a thrombus which is enhancing in the arterial phase and causing the expansion of the veins.
So it's a very important finding. So this is the arterial phase, and you can see that the portal vein is enhancing, which means that there is an arterial enhancing thrombus, or also called as a tumor thrombus in the portal vein. So that is a key point. So you remember this. Okay, so there is an arc and it is going through and through. So that's a very important finding. So in the arterial phase itself, you have almost diagnosed that this patient is likely to have HCC with cirrhosis. Okay, that's how you diagnose. That was classical arterial enhancing thrombus and portal vein expansion in there. As you know, there are two types of portal vein thrombus. One is due to tumor and one is planned. How do you differentiate between the two?
The arterial thrombus will not enhance.
It will not enhance the arterial phase. Like previously, you could see it was enhancing of the portal venous phase. And then obviously tumor thrombus, which is due to HCC, will enhance on arterial phase. Is there any other criteria?
If there is no obvious excessive mass.
No, in the portal vein itself, is there any other criteria?
Expansion
More than 16 millimeter is generally considered indicative of tumor thrombus. So these are the two criteria with which you say probably it is a tumor. Why is it important to say this? The tumor thrombus is there or not? Staging, yes, correct, very good. So that point you said. Now, what else is there in the liver? So you show the face of liver, and then we'll see the other structures.
There are two hypodense nodules, predominantly in the left lobe.
Okay.
There is ascites.
Yes.
And
Yeah, I think we'll keep this and we'll see them later. We'll just see the liver thing. Yeah. What else? What has happened in to the liver? Oh, this is the portal phase. This is a late arterial phase. Okay.
so here the enhancement is still persisting, and that the hypodense lesions are still there in the left lobe.
They are not enhancing. They are enhancing less than the liver. Correct. Okay. Next. Right lobe. What is happening to the right lobe? No obvious lesions. Okay. Next.
Even in the photovenous phase, there is no enhancement of the nodules seen in the left lobe. In the venous phase, there is a complete washout of the tumor thrombus in the portal vein, and there is no enhancement of the nodules in the left lobe.
Yes. So what is the conclusion? So we have seen almost all the cases now. So what will you say? we thought that there should be some tumor because there was arterial enhancing thrombus. But in the liver, nothing was seen. There is no enhancing lesion. So what will you say?
So in case of
When patient is having elevated AFP, in fact, the clinicians are coming and asking, where is the lesion? So what will you say?
in the background of elevated AFP, we have to consider HCC. Type of HCC for infiltrative or multicyclic HCC can present like this, where there is a diffuse involvement of the liver, and that's why the liver lobes can appear heterogeneous. And the main identification of infiltrative HCC is through the tumor thrombosis of the portal vein. On thrombosis of the portal vein, the perfusion of the organ changes. Hence, the classical characteristic enhancing pattern of the HCC will not be present in the infiltrative type of HCC.
Yeah. So also remember that one, as you said, the portal vein thrombus completely changes the dynamics of the liver and also the enhancement pattern. And second thing is when the HCC becomes large, it loses all its early arterial phase. All those features are it doesn't follow those rules. Particularly large HCC. As I said here, it's probably a diffuse type HCC where multiple nodules are there. So that is a most likely explanation. So that is about the liver. What other findings are there here?
So there is wall thickening seen in the liver esophagus with few perigastric, perisplenic, and some periportal collaterals.
So can you label what other collaterals are? One more important one. Around the gallbladder wall, there are collaterals, and also there are collaterals here. You can see these are the collaterals along the recanalized umbilical vein. Okay, so almost all the can you come down? Almost all the portosystemic collateral pathways are open here. Any other finding you read? Just think there is ascites. Anything else is there?
Wall thickening seen in the descending colon,
Yeah.
and even the transverse colon, and also in the ascending colon.
Okay.
So the wall thickening in the esophagus and in the colon might be due to portal hypertension, representing the portal colopathy.
Yeah, it is most likely. Many times it's quite difficult when you see this because initially we used to think is there an underlying malignancy until unless patient has symptoms. Always all consider all wall thickening as most likely portalless colopathy. It can present in various ways. From esophagus to colon, all the segments can be thickened. So it can also be due to hyperalbuminemia, various causes. But remember that bowel wall thickening is also one of the features of portal hypertension. Okay. So all the findings are there. So what is the final diagnosis that you can?
So considering the heterogeneous in the pattern of cirrhosis and raised AFP, the heterogeneous appearing liver and the arterially enhancing portal vein thrombus, the most likely diagnosis would be infiltrative HCC with there are signs of portal hypertension like collaterals and portal colopathy.
Yeah. So most likely, so remember that a large HCC may not follow the rules. So that I would say the message in this case. So, yeah. Any other questions, ma'am, you want to ask, or shall we proceed next? I think we'll proceed next. Yeah. So we'll start these quarters. So these are all like short cases or maybe one spot you can diagnose it. So this is a meme. So that shall we start? Okay. Okay. Now I think we'll go to Vanessa. So what do you think, Vanessa? Can you come? I can make it to slide. So what is the test that is done?
This is MRCP.
Okay, good. So what does it show?
This is the CBD.
Yes, good.
The main pancreatic.
That's correct. That's the main pancreatic duct. Good. Is there anything else that you are seeing? Yes, that's right. Your arrow is pointing correctly. So what is that?
They aren't.
Sorry?
The main pancreatic
Yeah.
duct is not fusing with
Correct.
the.
Correct. So it is fusing with what? Now you are on the right track. So this is the main pancreatic duct. It's also called as the dorsal pancreatic duct. So here is a ventral duct. So you can see, yeah, that's what. So here you can see that the ventral pancreatic is joining with the ampulla, whereas this is just goes to what is called as a minor papilla. Okay, so this is a case of pancreas division. So very briefly, we'll do the anatomy. So as you said correctly, so this is the dorsal duct which goes and joins separately. This is the ventral duct which joins with the CVD. This is the abnormal anatomy. This is the normal anatomy. The dorsal duct joins with the ventral duct generally, and it joins with the ampulla fluida. So remember that. So this is the dorsal duct joining separately. This is the ventral duct joining with the CVD. Okay. So can you identify this Chetana anatomical abnormality? I put an arrow to help you out.
There is another of the.
No, it's a variation. Yeah, it's a variation, anatomical variation. Is there anything that you can identify? The little tricky one. So the image may not be correct. So this is this is a CBD. Okay, this is a gallbladder. This is a cystic duct. Okay, oh, sorry. My God, actually, that's okay. So what happened is that this is the anterior right hepatic duct. This is the left hepatic duct. So this is the right posterior duct which goes and joins the common duct. So here one more, it is joining cystic duct also. This is the most common anomaly of the biliary, and to some extent there's got some significance because surgeons, if you say like if it is attend low, then they'll be little carefully ligate. So that is the key thing. Remember the right posterior hepatic duct which is joining separately the common duct. So that is the anatomical variation. Is it clear? Aberrant right hepatic directly joins the common hepatic duct. Okay, now this is to Vanessa. Is there anything abnormal? Again, it is a variant. I'll give a clue. Anatomical variant. May be difficult. Let's see.
So,
That's right. Okay. That's the hepatic artery. So hepatic artery is doing what? Hepatic artery is what? Arising from, yeah. Again, I think the images are, yeah, that's right. So if you see, yeah, see, this image may not be very clear. So this was the celiac trunk, and this is the, yeah, superior. So here you can see that the hepatic artery is going, arising from the superior mesenteric artery. So this is called as what? Replaced. Why is it important?
During
Both, yeah, both during surgery it's important. Even someone wants to intervention, they want to know where the hepatic artery is coming, so it helps them. So it's an important anatomy which we supposed to mention in the CT. Okay. So let's go one more variation. Little tough variations I'll give one. Let's. No, it's a variation. Just look for any variation in anatomy that you can see. So very clue is very rare. This thing. Yeah, that's it. The pancreas. So what is it? Not annular pancreas, some anomaly of pancreas. I agree with you. Yeah, that's it. I think Vanessa is speaking up. Yeah, what is that? Yeah, that's the thing. So you can see that this is the ventral part which is remaining, but this part is replaced by the fat. So this is called as a dorsal agenesis of the pancreas, which again is a very rare abnormality. Dorsal agenesis of the pancreas. Now we go to the pathological ones. Okay. Vanessa, can you pick up the abnormality?
There is dilated CBD,
Dilated CBD.
and
Okay.
dilated pancreatic,
Yes, correct.
doubled up.
See, anatomy is little complicated. This is the common bile duct, which is not dilated. This is the pancreatic duct, which is dilated. Is there anything else you want to say? What is this? To which the pancreatic duct seems to communicate. So what is this? So this is a sort of a hypodensity or a cystic structure to which a dilated pancreatic duct communicates.
IPF.
Yeah, that's so. If you see this, this is the classical of IPM. Okay, so that is the one of the classical features of IPM, and here you see a cyst or hypodensity to which the pancreatic duct communicates. This was an IPM and intrapapillary mucinous tumor. Now to change this is what this has done. Yeah. Yeah. Is there anything else that you want to see? I agree with you. There is bilobar intraparticular radical diagnosis. Now, what has happened to the? Yeah. So that's right. This is a classical. What is this classical? This is a classic called as a hilar collagen clamped skin tumor, where she is seeing a mass, and this is a CBD. As you correctly said, the CBD is not dilated. So this type of an obstruction. Do you know the types of obstruction? That is what is called as a Bismuth classification is there. So this, yeah, I mean there are like various, like one is more than 2 centimeter, two is less than 2 centimeter, and 3 and 3B depending on that's going to right and left, and 4 is extending both. There are other variations of this classification also. So that's a hilar cholangiocarcinoma. So now this one, so that is the little difficult one. Let's see.
There is air.
Yeah, very
within
good.
the
Yeah, so that's post procedural. They have done some procedure. Okay, then
there is
what else is there? Anything else you can find? There's something there. Yeah.
there is intrahepatic biliary
Yeah, very good.
radical on the right side.
Yeah, and on the left side also you can see. Correct, isn't it? Here, this is the left side dilatation. This one. So what do you think it is? Possibly what? Any clue is there in this image? Just say what is the diagnosis? See, as you said correctly, many times we have to see the plain image. Suppose you see this in the plain image, what would you have said? Sorry? And within the bile duct, not with that. So this will be a soft calculus. Okay. So you see dilated bile ducts and you see calculi within them. So what is it called as? Oriental Collagen or recurrent pyogenic cholangitis. So this is a known case of recurrent pyogenic cholangitis. Dilated ducts, Oriental Collagen. Okay. Now we go to Chaitanya. So what is this diagram? One is arterial phase, another is little delay. So what will you say? Hmm. 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 Yeah, it's called as a, yes, that's right, you picked up. It's a giant hemangioma. The clue always is look that the vessels or an enhancement pattern in hemangioma always follows that of the blood pool. So you can see here they are of same density. Here also you can see the enhancement is of the same density. So that it, although it may not fill completely, but centripetal pattern of enhancement and the enhancement pattern being similar to blood pool indicate that this is most likely it is a hemangioma. Giant hemangioma is considered when more than 6 centimeters is there. So I think this is true. So can you have put 3 ladies? So can you? What are the common pancreatic tumors by age? Can you tell?
So daughter, mother, and grandmother.
Yeah, that's right.
So daughter region is and some
Yes.
pseudo-papillary epithelial neoplasm.
Yes.
Mother lesion is pancreatic mysterious cystidenoma, cystidenoma.
Yeah, correct.
And grandmother lesion is serous cystidenoma.
Yeah, correct. So you answered it brilliantly. As I said, this is daughter is solid pseudocapillary, mother is business cystic, and grandma is serous cystic. So these are the examples. There is solid cystic mass, and here you get a mucinous cyst with peripheral calcification, whereas serous cyst will have septation, thin septation, and central calcification. That's the in general. There is one grandfather tumor. I've heard it's not very commonly described in practice. IPM is supposed to be grandfather tumor. Good. So this one last two again to Chaitanya. So can you? There are two lesions. The upper there is one lesion and lower there is one lesion. So can you? This is a slide I've taken from radio assisted. I liked it very much, so I just lifted it. So so what do you think is happening here? Yeah. 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 Very good. So this one here.
Arterial there is enhancement and there is a persistence of the enhancement in the venous space.
Yeah.
Since it is hypodense, it could be some adenoma or metastasis.
Yeah, I think the upper you answered correctly. This is easy because there is washout. So here, what I would say is it is retaining contrast, and it is compared to blood pool, it is same. So I would say it is more of a hemangioma. Remember that a small hemangioma can show complete filling on the arterial phase itself. So this is how to differentiate between. So the key thing is, as you said correctly, above is malignant, there is washout, and below there is retention of the contrast, so which indicates that it's a benign lesion. So in final, can you tell something about the Lyra's classification?
So Lyra's classification is solo to characterize the lesions in the serotic patients. In the background,
And also chronic hepatitis B,
chronic hepatitis
who are not serotic.
In background cirrhosis and chronic hepatitis B, they are more risky to develop HCCs. So, if we find out any lesion in these patients, we have to follow Lyra's criteria.
Very briefly, what are the major criteria? Do you remember that?
Lyra's one is definitely benign lesions. Lyra's two is probably benign lesions. Lyra's three will be intermediate. Lyra's four probably HCC, and Lyra's five will be definitely HCC lesions. And we also have Lyra's M, which will indicate malignant lesions other than HCC. Lyra's PIV is there, which includes lesions with tumor in veins, and there is also Lyra's TR to classify the treated malignant cases in cirrhotic patients.
And what are the major criteria? Do you know what are the major criteria to say lesion is malignant?
So, if the lesion is more than 2 centimeter, there is arterial phase enhancement and
Non-peripheral arterial phase enhancement. Then
if there is more than 50% change in cell, increase in size,
then
and the capsule is
capsule enhancement. Capsule enhancement is appreciated in which phase? Delayed and venous phases. And then one more criteria is there. Washout. Washout. So what is washout? Definition of washout?
Washout is when compared to the adjacent liver parenchyma, if the lesion is appearing hypo,
Lesion is losing contrast in venous and portal venous and delayed phases. So remember that a lesion is that is enhancing becomes less dense than rest of the liver. That you say that it is doing washout. Ma'am, we are through. So anything else you want to ask?
Yeah, yeah, it was a very good, nice case discussion. And the spotter session was absolutely wonderful because it was really very helpful for the students, all the spotters. And the three ladies which you showed with the tumors coming in the family is really very, very nice. I liked it. Anish? Yeah.
Yeah. Yes. Kiran sir, it was a good session. The cases were interesting and your spotters were excellent. I thank you for coming and joining with us for the session. I thank your PGs, Dr. Chetana and Dr. Vanessa, for your excellent participation. I thank IRIA State President, Gomati Subramaniam ma'am, Academic Chairman, Venu sir, Academic Coordinator, State Academic Coordinator, Ramesh Shenoy sir, Rijo sir, Secretary IRIA Kerala, for having such a interesting PG sessions. I thank our platform supported by Mindray for their support. I thank you all who are listening to the session, the residents and the radiologists for there. Meanwhile, I invite you all again for our next session that will be on next Thursday. Details will be shared soon. So hope we will meet again there. Thank you, ma'am.
Thank you once again, Dr. Krishna Kiran, for without any hesitation, you told yes. I was very happy when you said yes. So thank you, Dr. Krishna Kiran, and your residents also.
Thank you, ma'am. Thank you for giving us the opportunity.
Okay. Thank you so much. Okay.
Okay.
We can leave the session.
Yeah, ma'am, I'm ending the session.
Yeah, okay. Thank you.